Assalamu alaikum. Welcome to Sysytem RCOG. Today I will explain cardiology introduction. Before I explained the maternal medicine module introduction, and I started by explanation of the template for structured discussion, so I will apply my general template on cardiac patients today. We have to start by assessment of the disease severity, so her cardiac condition should be assessed by asking her about duration of the disease, if she has any symptoms like palpitations, dyspnea, having orthopnea, fatigue, level of activities, housework activity, office job, running, shopping, and last follow-up with the specialist and last echo. At the end, you will know if this patient is low or high risk. We need to ask about obstetric history of current and previous pregnancy, including if it is first pregnancy, was it planned, if she's happy to continue, and what about the result, any complication like results of the booking bloods, dating scan, 20-week scan, in order to know if she has any complication in the current pregnancy. And this patient will need history. This history should include both current and previous pregnancies. We have to review her medications, including folic acid, if she was in ACE or ARBs, because usually they give them in order to maintain the blood pressure, prevent hypertension. Patient could be on low molecular weight heparin or no. And then at the end, we need to tell her what she needs to continue and what she needs to discontinue. We need to take also the obstetric history, which will include the parity, whether first pregnancy, was it planned? Usually it will be unplanned pregnancy, and if it is unplanned, we will ask her if she's happy to continue or no. If she received folic acid, and what about the follow-up of her pregnancy, any complications? So we have to ask about the dating scan, the 20-week scan, the basic. Then we have to cover this obstetric history in both current and previous pregnancies. We have to review the medications, including folic acid. If the patient is on any antihypertensive medication like ACE or ARBs, which need to be discontinued, and some patient may be already on low molecular weight heparin, because VTE could be higher in some cardiac conditions, like the valve, the artificial valve. We will decide together with the patient what we need to continue in the medication and what we need to discontinue. And of course, everything should be justified. We need to examine the patient. In a structured discussion, please, you need to tell examiner what need for examination. Usually, cardiac patients need regular assessment for the blood pressure, pulse, and checking the heart state, whether she has any murmurs, whether she has change in the character of existing murmurs. And usually we need to examine by the same doctor each time in order to be able to differentiate any change or pick up any change with in the patient condition. We have to give information to the patient. The first will be implications or the effect of the pregnancy on the condition and vice versa on her heart. Usually the effect will be heart failure, stroke, cardiac arrhythmias. In the fetus, it will be neonatal morbidity and mortality from growth restriction and retardation, prematurity, and prematurity are markedly increased. Prematurity could be iatrogenic or spontaneous. We have to give her the plan of care. It will be under the applied knowledge domain, preconceptional, antenatal, or postnatal plan, and we have to educate the patient. It depends upon the condition whether we have to give her any education. And in the plan of care, you have to remember multidisciplinary team, frequent visits, and screening, because depending upon the condition, we may need to screen her for the risks. Coming to simulated patient tasks, we have history, and we have to assess the disease severity by a set of questions. Open one: can you tell me more about your condition? For how long have you been diagnosed with the condition and how it was diagnosed? Currently, do you have any problem? Awareness of heartbeat, difficulty in breathing. Can you do activities and around the house? And our aim is to assess the grade of NYHA state and the job. It could be office job or active job. And when was your last follow-up? Review her medication. They are given the antihypertensive medications in order to prevent high blood pressure in order to protect the heart. Any recent admissions. Sometimes the patient will be admitted in her history to the ICU. Some patients may tell you that she has flashbacks, and here will come the issue of empathy and communication. Her obstetric history, including current pregnancy, usually unplanned. Ask if she's happy to continue, whether she was in any kind of contraception. Usually she will be either on the condom or in some type of mini pill, and she's irregularly using them. Could be also an implanon, which was missed the due date. So any previous pregnancy, if any, and if she received folic acid. If she has previous pregnancy and there is a miscarriage, you have to inquire about since how long, gestational age, and how was terminated, if was confirmed clinically or no by ultrasound or pregnancy test. How was it terminated and how was her recovery? And if she mentions that she had some bleeding during the any of the miscarriages, please ask about the blood group, and if it is negative, you have to ask about the NTD. Then coming to the gynae history, early pregnancy or preconceptional, we have to ask about last period, contraception, and the smear history. In the family history and the partner, if it is genetic condition, ask her if about the health of the partner and if she has family history positive for this condition. For example, Marfan's disease, Marfan's syndrome. Sure, she will have family history positive. And then in the social history, you have to cover the support network around the patient, from her family, from her partner, the smoking, the alcohol, and the drugs. The BMI should be discovered early in the station. If we have high BMI, we have many questions to add. Psychological well-being should be assessed. It is a chronic condition affecting patient quality of life, and also patient could be psychologically affected and needs psychological support. Examination, usually it will be given to you and you have to just explain it to her, but you don't have to examine the patient in the simulated task. And in the investigation, if they give you some investigation, explain, and if it is not mentioned, you have to add what investigation you need to evaluate her condition. Usually we do urgent assessment if the patient missed her last appointment, and usually they will tell you, I missed my last appointment with a cardiologist, or she did the echo since 4 months. So they are testing you for your safety, and you have to tell her as soon as possible or urgently, I will involve the cardiologist in order to do this and this to evaluate your condition. We can see the assessment and the classification also depend upon the module. Coming to counseling in cardiac patient, we may have, after we gather information, we will assess the risk. Patient could be low, moderate, or high according to the TOG article, depending upon the module. If the patient is in the preconceptional period and the pregnancy is assessed to be not safe right now for her, it could be not safe or not recommended at all. But let's say if the patient is low or moderate risk and she can get pregnant, but it is not safe for her right now to get pregnant, so we have to tell her it is not safe for her, and we can postpone until we optimize her condition. To start folic acid, to review by the specialist and take his opinion, and to change that medication. After we review the medication, she could be in teratogenic medication, which should be stopped. Some medication need to be stopped 3 months before the pregnancy. Some of them could be less. Until optimizing also her social habits. If she is smoking or drinking alcohol, if she's obese and needs to lose the weight, our justification is when we follow this advice, we can reduce the risks and complications which can happen during the pregnancy. Then we will explain to her what could be the implications, and the implications are different between low risk and high risk patient. Low risk patient in low risk condition, we will reassure her and tell her that most women with this condition will have healthy baby and healthy pregnancy. I will tell you an example of this low risk patient. If she has VSD, ASD corrected when she was a child, now she is asymptomatic and not following with any cardiologist. Pregnancy will not add any risk to the heart, and she will be low risk, and she can follow with the GP, even with the midwife. We have to explain to her every risk and how can we minimize. We can use it do it like trimester wise. This is the most empathetic way, non-terrifying, which is important in communication with the patient. Please add fix it. That the outcome of the baby depend upon how her heart cope with the pregnancy. medication and the gestation at delivery. So it could be reassuring, but also it depends upon three things. Usually the effect could include miscarriage, abnormal development, low birth weight, preterm labor, baby could die in the womb. If it is a genetic condition, the condition can go to the baby, and we will tell her how the pregnancy can affect her condition, and in low risk, the heart can tolerate the pregnancy well with the proper care. If she has high risk condition, it will include actually the very high risk case like Marfan syndrome and like pulmonary hypertension. So we have to be very empathetic here. Sometimes we will offer termination, but you will not recommend. Okay, so you will just tell her that you can have the option of termination or continuation, and you have to explain to her why, and wait for her wish. You have to respect her wish and highlight the autonomy, and you have to tell her the care in both situations, whether she terminate or continue. And it depends upon the disease, the condition. So Marfan syndrome with aortic root below 4 cm is different from pulmonary hypertension. Mortality rate here is 1%, and there it is 30%. So we can recommend termination in pulmonary hypertension, but we will just give her explain pros and cons of termination versus continuation, and she can choose. Also at the point, outcome depend upon how her heart cope with the pregnancy, but this is and the medication, and if she delivered early, gestation at delivery. And these are the same usual complications, but of course incidence is much higher, much expected. So the risk of death should be included. And if you didn't mention, it could be failure. So pregnancy, make it like logic sequence. Pregnancy your heart already is at risk, and pregnancy will increase the burden on your heart. Eventually heart failure can happen, so your heart will not be pumping well and fail to do the function, and you need to be admitted to the hospital. Your admission will be in the special care. Actually, she will need, even after delivery, admission to special care. And sadly, death can occur in person depending upon the condition, and risk of death could be could be also in termination. So termination is not completely free of the risk of the death. That's why the multidisciplinary team should be caring for the woman, whether she will continue or will terminate the pregnancy. Also, medication should be reviewed in case she will terminate the pregnancy. And usually we will advise the patient never to discontinue her medication without review. We have some predictors for the bad outcome in the patient, in the maternal cardiac event or the baby event, and adverse neonatal events. And also we have indications for cesarean section. You need to be aware of this slide from TOG article. So that's why very important to ask the patient about evaluate her cardiac state if she had previously any heart failure, admission to special care, and if she evaluate her NYHA, because the class more than 2 or cyanosis is risky, and if she has left heart obstruction, so if in mitral valve stenosis, if it is below 2 cm, aortic valve area stenotic below 1.5 square cm, or if she had peak ventricular outflow tract gradient more than 30 mm of mercury by the echo. If she had ejection fraction below 40, and the predictors of the adverse neonatal events will be NYHA class more than 2 or cyanosis during the baseline prenatal visit, maternal left ventricle obstruction. So you notice here in the red outline here and here that the patient and the baby have bad predictors which are similar to each other here and here. Left outflow obstruction and NYHA class 2, it will be risky to both mother and baby. If she is smoking, multiple gestation, if she already on anticoagulant during the pregnancy. We have indications for cesarean section. You can tell about the mood of the delivery, admission to special care during the antenatal care plan. It usually don't come in the delivery or post-delivery. It will come in the antenatal plan when you discuss with the patient. So if the patient have aortopathy with aortic root more than 4 cm, dissection, aortic dissection or aneurysm, if the patient was in warfarin within the past 2 weeks, because the baby could have intracranial hemorrhage, of course. And during delivery, there will be compression, decompression, and the intracranial hemorrhage can occur. This is a NYHA classification, which help in evaluation of the risk. And simply, a single question can differentiate if she feels this neck at rest or she can do activities around house. If she mentioned, no, I don't have any limitation, I can do housework, I can do walking, moving around the shops, I can do swimming. So this patient has no limitation and she will be classed as 1. If she mentions that she feels comfortable at rest, but she can do a little bit some activity around house, but after that she will be fatigued. So ordinary activity, which is housework, will lead to fatigue and palpitation. Now, but she feels okay at rest. So it will be 2. More than 2 is one of the bad predictors for the maternal and fetal outcome. 1 is okay, no limitation. We have 3. She has marked limitation and less than the ordinary activity. She's still comfortable at rest, but less than ordinary activity can make her fatigue. And the class 4, she is unable to do any physical activity without discomfort. And this is the summary of the TOG article about the low risk, moderate, and high risk cardiac lesions. I will go through them rapidly, the most important points only. You don't have to know the details in part 3, but of course in part 2 you need to know. The outlook. We have the low risk lesions. We have small left to right shunts like ASCD, VSCD, and PDA, coarctation of the aorta, and tetralogy of Fallot. The outlook in small left to right shunt, what is expected? Expected it will improve during the pregnancy. Why? Because there will be decrease in the peripheral vascular resistance, which will decrease left to right shunting. In absence of pulmonary hypertension, pregnancy, labor, and delivery are well tolerated, but there is the risk of atrial arrhythmia and emboli. So these are one of the conditions. This is one of the conditions where patients should receive thromboprophylaxis. The risk during the labor will be acute blood loss. Any acute blood loss or vasodilatation can affect the direction of the intracardiac shunting acutely and reduce the left ventricle output. So we have to prevent the bleeding or the blood loss during the delivery. Coming to coarctation of the aorta. Coarctation pregnancy is usually well tolerated in women with adequately repaired coarctation. What could be the risks? Could be dissection, aortic dissection, rupture, resistant hypertension, and for the baby will be growth restriction, abruption, and premature delivery. For the mother, preeclamptic toxemia, hypertensive crisis, and rupture of intracranial aneurysm. How we manage? Usually, be careful and give beta blockers and monitor the fetal growth. In tetralogy of Fallot, low risk lesion with repaired tetralogy of Fallot, pregnancy will be well tolerated. So in general, in the low risk lesion, we have to reassure her that the pregnancy will be well tolerated by proper care. Arrhythmia, right ventricle failure, right ventricle outflow obstruction, and the pulmonary hypertension will be the risks. And in this patient, in the preconceptional care, we have to do echo, give her diuretics, admission, and bed rest. And during the antenatal care, she will need regular cardiac review whether the patient was repaired coarctation, tetralogy of Fallot or no. Moderate risk lesions. We have cyanotic heart disease with pulmonary hypertension, transposition of great arteries, and Fontan circulation. Outlook is the most important here. Effect of the pregnancy on cyanotic heart disease. Pregnancy with fall of the systemic vascular resistance and rise in the cardiac output will exacerbate the right to the left shunt, and this will worsen the pre-existing cyanosis and hypoxia. And the risk depend on the ventricular function, include hemorrhage, paradoxical emboli, and heart failure. Risks to the baby could include miscarriage, 30 to 50% risk of premature delivery and low birth weight. Degree of maternal hypoxemia is the most important predictor of the neonatal outcome. Transposition of great arteries. Pregnancy is well tolerated following an uncomplicated repair, and in women with long-term complication, pregnancy is poorly tolerated with increased risk of cardiac complications. The risks include systemic right ventricle failure, tricuspid regurg, sinus nodal dysfunction, and arrhythmias. And many women with corrected TGA are on AC inhibitors. Fontan circulation, single functional ventricle, and risks is low in NYHA class 1 and 2, and the concern is heart failure and arrhythmia. Then the high-risk lesions will include the Marfan syndrome and pulmonary vascular disease. Pregnancy depends upon the aortic root diameter in Marfan syndrome, whether it's below or above 4 cm. Mortality rate, if it is below 4 cm, around 1%, and rise to 25% if the aortic root diameter is more than 4 cm. The risk here is aneurysm and dissection of the aorta and aortic rupture. If you see the patient in the preconceptional period, you have to postpone until aortic replacement is done if the diameter is more than 4 cm. If the patient has unplanned pregnancy, you have to offer her termination. And serial aortic root diameter by echo, and give beta blockers to protect her against the dissection and aggressive treatment of hypertension. Pulmonary vascular disease, pregnancy is poorly tolerated. There will be worsening cyanosis, hypoxia, arrhythmia, and heart failure and death. Mortality 36% in Eisenmenger syndrome, and 30% in primary pulmonary hypertension, 56% in secondary pulmonary hypertension. In unplanned pregnancy, we have to offer the termination. Mortality rate will be 7% with the termination. Fetal morbidity and mortality is considerable with premature delivery, restricted growth restriction in 50% of cases, and only 50 to 25 pregnancies reach the term. Who select to continue require close cardiovascular monitoring and bed rest from the third trimester with monitoring up to 14 days postpartum. Usually they receive anticoagulation, oxygen therapy, and pulmonary vasodilators, and like nitric oxide and prostacyclin. Coming to the antenatal care, explain to her the antenatal care. Tell her, let me take you through the course of pregnancy. Is that okay? You will be cared by a multidisciplinary team, including consultant, cardiac specialist, midwife and specialist nurse, dietitian, and anesthetist. You will have more frequent visits to keep eye on you and your baby. You will have, in addition to the routine dating scan and the 20-week scan, additional care. So you will explain to her the care required to reduce each implication trimester-wise. In addition to the routine, you will have 20-week scan. This is routine, but we will tell her, highlight it and mention the reason. Because we need to assess the structure of the baby, particularly if the condition is genetic, can pass to the baby and affect the baby heart, or the medication used during the pregnancy can affect the baby. So we will do detailed structure for the baby and detailed structure scan for the baby, in addition to 22-week scan for the heart. And baby may not grow as well as expected, so we will do regular growth scans. We may do a plan for induction of the labor at term, or maybe early in case of complication happened. We have to review her medication and refer her to the specialist to stop teratogenic medications and give her alternative medications, and ask her if she has a specific plan. Coming to the plan for the labor and delivery, we have certain principles for cardiac patients. Vaginal delivery, low-dose epidural anesthesia is the mode of choice. Monitoring for both mother and baby. Preload and blood pressure should be monitored carefully. Blood loss should be minimized. Left lateral position is recommended. Forceps or ventouse delivery can be used to shorten maternal expulsive effort in second stage of labor. Antibiotic prophylaxis for infective endocarditis is not recommended routinely as per NICE guideline. We have certain indications for cesarean section, aortopathy with aortic root more than 4 cm, aortic dissection and or aneurysm, and warfarin treatment within 2 weeks. In third stage of labor, bolus doses of oxytocin should be avoided, as this can lead to severe hypotension. Low-dose oxytocin infusions are safer. Ergometrin should be avoided in most of cases, as it can cause acute hypertension. Uterine compression sutures can be helpful in the management of uterine atony at cesarean section. The safety of misoprostol is yet to be determined. Coming to postpartum, careful hemodynamic monitoring postpartum is typically required for 24 to 72 hours, but this should be extended to 1 to 10 to 14 days in women with pulmonary hypertension. Multidisciplinary follow-up should take place 6 weeks after delivery. Thank you so much and stay tuned.